Thank you, Peter, for that very kind and generous introduction, and welcome, ladies and gentlemen. It's a great honour to be invited to give the Harry Perkins Oration in memory and recognition of the late Harry Perkins, who, as you've heard, played a pivotal role in creating the West Australian Institute of Medical Research in 1998 and was the inaugural chairman. And as a tribute to Harry's leadership and vision, which has underpinned the success and direction of the Institute today, it was renamed after him at this oration by John Eichelboom 2 years ago. Since those 2 years, we've seen the opening of these landmark buildings commemorating, they are the Perkins Institute on the QE2 and Fiona Stanley Health campuses. And here, a load of multidisciplinary research is undertaken to address key research questions in major health priority areas. And today we're going to just focus on one of these, which is the prevention and treatment of blocked blood vessels to the brain. So in this afternoon stroll, I'm going to ask you to contemplate 5 real issues. What is a stroke? What causes it? Why is it important? How can we contain the increasing burden and future directions? Now, to some of us, a stroke is a sporting stroke. To others, it's a soothing, perhaps even sensual, tactile stroke. To others, it's a metaphor, a stroke of luck or a stroke of genius. But in the context we're talking about today, it's derived from the Greek word apoplexy, to be struck down as if by a thunderbolt that we saw on Scarborough Beach this time last week almost. So it's the suddenness of a loss of function of a particular part of the body, such as depicted here, loss of strength in the left arm and leg. And it's due to a sudden loss of function of a part of the brain that subserves that function. And, for example, strength, feeling, speech, vision. And it's due to a sudden disturbance in the blood supply and hence the oxygen and sugar carriage and supply to that part of the brain. So if we block the middle cerebral artery here on the left side, we'll have weakness on the right arm and leg, loss of feeling on the right arm and leg, unable to speak and unable to see to the right side. There are 2 main pathological types of stroke. One is a burst blood vessel to the brain, called a hemorrhagic stroke, that makes up about 1 in 6 to 1 in 4 strokes. And we can see it here, or on a brain scan, a CT scan. This is the front of the head, this is the back of the head, this is the skull bone, this is the brain, and blood shows up straight away as a white blob. The other, more common form of stroke is a blocked vessel to the brain that makes up about 3/4 of stroke, a so-called ischemic stroke. And this blockage is usually due to a clot that's come from upstream in the heart or the aortic arch in the chest or the neck. And it's depicted here on this CT scan, again the front of the head, the back, and you can see on the first day and then on the 3rd day a large area of infarcted or dead brain due to no blood supply. What is a TIA? Well, that's a brief lack of blood supply to a part of the brain, and traditionally we used to define it by the Earth's rotation, someone whose symptoms resolved within 24 hours. But we've realised there's more to it than that. And it's now defined as someone who doesn't have infarction of the brain, no residual damage, but who has had those symptoms that are usually transient. It's not worth getting too bogged down between a TIA and a mild ischemic stroke, because as you can see from the time of onset, the risk of having another stroke for people with a TIA in white and a minor stroke in yellow is about the same. So they have the same causes and the same prognosis. So we consider them fairly similar. But what I will draw your attention to is 1 in 10 people who have a TIA or minor stroke have another fatal or major stroke within a week. So that's why that can be a medical emergency, to get on with it. So what causes stroke and TIA? Well, as we said, hemorrhagic stroke is about 1/4 of strokes, and it's usually due to disease of the blood vessels or thin blood. And the most common cause of bleeding deep in the brain is high blood pressure, because it damages the small blood vessels over time and makes them prone to rupture. If someone has a bleed out on the surface of the brain, if they're an old man like me, it's probably amyloid angiopathy, but if it's a young girl like here, it was an arteriovenous blood vessel malformation. Bleeding over the surface of the brain, called a subarachnoid hemorrhage that we see around here on the scan, this white stuff, is usually due to a blood blister, an aneurysm that's formed in one of the blood vessels, often due to a positive family history. There's a genetic predisposition, but also high blood pressure, smoking and alcohol causes these things that can cause sudden death, often in young people. What about the more common form of stroke, a blocked blood vessel to the brain? Well, usually it's a blood clot that's come from the heart or the blood vessels in the chest or the neck, or it's due to intracranial, within the head, small blood vessel disease. But the most common cause now is actually clots coming from the heart. And the most common cause of that is an irregular heartbeat, atrial fibrillation, that predisposes to stasis of blood in that chamber. And you know, if you cut yourself and blood falls on the floor and it'll clot. Well, if blood stagnates in a chamber like the left atrium or left ventricle, in this case the atrium, you'll see a clot form here that doesn't look too big, but it's big enough to block your carotid artery and be fatal or disabling. And the most common cause of this is uncontrolled blood pressure and ischemic heart disease. And that's why it's so common and increasingly common as we're getting older. Another cause of clots forming in the heart and going to the brain is previous heart attack. This is an ultrasound of the left ventricle and the left atrium of the heart, and we can see because of the heart attack here that's compromised the blood flow to this part of the muscle, it's not beating properly like these other parts, and so there's stagnant flow here and a clot forming that can break off and go to the brain. In addition to clots coming from the heart, the other major cause of stroke is atherosclerosis in the aortic arch in the chest, the arteries in the neck or in the brain. And this is what it looks like as we're laying it down in our blood vessels in our neck, in our coronary arteries, in our arteries to our kidneys and our legs. And it's caused by prolonged exposure to the 4 horsemen of the apocalypse of stroke: high blood pressure, diabetes, smoking and high fats in the blood. And it's also predisposed to by what we've inherited from our parents, perhaps our prenatal nutrition, and certainly how we conduct ourselves and behave ourselves as a younger person and as we get older. Lifestyle and diet are incredibly important. Now, atheroma is like a volcano. It's usually dormant for a long time, sitting like this in our blood vessels with a large core of fat and a thick cap. So it's pretty stable and robust. But then sometime the plaque here becomes inflamed, and we're not quite sure why. But it may be infection and it may be other things, but the plaque becomes unstable, and when it's inflamed the covering becomes weak and thin, and it may rupture one day and blood will get into the wall like in here, and the blood will then think you've cut yourself. When the blood gets exposed to the wall, it thinks you've cut yourself like shaving, and so it forms a clot to fill up this gap, but the clot breaks off like here and up it goes to your brain. And we don't quite know what triggers the rupture of these plaques, and if we knew, someone would win a Nobel Prize. But there have been, this has been the rationale for some trials of vaccines to reduce infection. And there are other means by which plaques can become inflamed. And the third cause is blockage to the small penetrating arteries within the brain that can cause a small little infarct or stroke like this in the internal capsule. Now, although it's just a small blood vessel blocked and it's just a small part of the brain taken out, you can see that because the face, arm and leg fibres come from the cortex down through this dog-leg capsule, if you have a small stroke there, it's like taking out central Perth. You take out Joondalup and you take out Hillary's, and you can become completely paralysed down one side just with a small little blockage to one tiny perforating artery. So what I'm trying to convey is that stroke is very heterogeneous. If someone has a sudden loss of function of a particular part of the brain, it may not be a stroke, it may be a seizure, it may be multiple sclerosis. But usually it's a blocked blood vessel or occasionally a burst blood vessel into the brain or over the surface. And if it's a blocked blood vessel, it could be a clot coming from the heart, it could be a clot coming from the major arteries in the neck, it could be intracranial small vessel disease, it could be many other things too. And so there's no wonder there's no magic bullet to prevent every stroke or to treat every stroke. It's a heterogeneous condition. So why is stroke important? Well, firstly, it's common. In Western Australia, we have 5,000 people have a new stroke each year pouring into the bathtub. 13 a day, 1 every 2 hours. And within this bathtub, there are 41,000 people living here in Western Australia who have survived a stroke. 1 in 200 of all of us. 1 in 50 of people of my age at 58. So it's common. And the other problem with it is frequently fatal in 1 in 5 people and disabling in up to half of people who survive. So we have 14,000 people living with disability due to stroke in this state, and we have nearly 1,000 people dying, or 2.5 a day, from stroke. Indeed, in the world, out of 291 diseases and injuries in 21 regions of the world, stroke is the second most common cause of death behind ischemic heart disease, causing 1 in 10 deaths in the world. More importantly, it is the third most common cause of disability-adjusted life years lost. That's the number of healthy years lost due to ill health, disability or early death. That's quality of life. And there's only lower respiratory infections in ischemic heart disease that are greater causes of disability-adjusted life years lost. Thirdly, the burden of stroke isn't just great, it's increasing. When we looked in 1990 at all the strokes in the world, we saw that there were 10 million new strokes each year. In 2010, there's 16 million. We've had an increase of nearly 7 million new strokes, or 2/3 in the last 20 years. The number of stroke survivors has increased in the world from 18 million to 33, an increase nearly double of 15 million people living with stroke. Disability-adjusted life years lost have increased from 86 to 102 million, a 20% increase. And deaths due to stroke has increased from 4.6 to 5.8 million, an increase by 1.2 million, or 25% in the world in the last 20 years. The good news is stroke's preventable. In high-income countries, we've conducted studies of the incidence of stroke in the 70s, 80s, 90s and 2000s, and we've seen the incidence, the number of strokes per 100,000 people each year, falling by about 1% a year, or 42% from 160 to 100,000 to 94. And our 3 studies in little old Perth here show exactly the same trend. We found a reduction in Perth from 1980 to 1990s to 2000 of stroke incidence also by about 40%. So we're preventing strokes, the number of strokes per 100,000 of us. However, in low-income countries like in Asia, etc., stroke incidence is increasing by 5% per year. So the net effect on stroke incidence in the world is pretty equivalent or stable. We can see it's 250 per 100,000 in 1990 through the world, 257 per 100,000 in 2010 through the world. The good news is, though, stroke's treatable. Despite a stable incidence rate of the tap dripping here, the death rate is actually falling from 107 per 100,000 to 88. So there's a reduction in death rate and disability-adjusted life years per 100,000 people. The trouble is the number of 100,000 people is increasing. So despite declining incidence rates in Australia from 97 to 2009, reduced rates per 100,000, the actual number of strokes is increasing. And that's because there's more of us. We're increasing in numbers from 20 million to it's going to be 30 million. And the people who are at risk of stroke, the elderly, we're going to be a greater number as well than we've been. And so because of the population growth, and particularly the growth of the population at high risk, despite the fact that we're preventing stroke and having less per 100,000, and we're treating better and having less case fatality per 100,000, the fact is we got more people and the numbers are increasing. So how is the government going to deal with this looming epidemic, and how are we going to contain the looming epidemic? So there's two main strategies. One is prevention and the other is cure. So firstly, we've got to turn off the tap and reduce the incidence and prevent stroke. And because 70% of all strokes are first ever, we have to do it in primary care. Doctors like me who see people once they've had a stroke only make up 30% of all recurrent strokes. So if we were completely effective, we could only reduce the burden of stroke by 30%. It has to come from good primary care and good primary prevention. And one strategy is to lower the risk level of everyone in the population. So we have this distribution of the frequency of a risk factor like blood pressure, for example. Some have it high, some have it low, but most have a medium blood pressure. We need to get everyone's down, and then you get rid of the people who are diseased. So what are the risk factors? Well, we've just looked at 13,000 cases of first stroke and compared them to 13,000 people who haven't had a stroke in 32 countries. And we found that 90% of all strokes are attributable to high blood pressure, lack of exercise, high fats, poor diet, high waist-hip ratio, diabetes, alcohol, smoking, and heart problems, atrial fibrillation. So if we can lower the prevalence of those risk factors in the community by public education, health policy, legislation and taxation, such as has been achieved with the Quit campaign, reducing the prevalence of smoking in Australia from 1 in 3 in 1980s to now about 1 in 6, we can reduce the risk of stroke, because there's no doubt that every cigarette you smoke, the odds of a stroke increases. Every 10 you smoke, the odds of a stroke increases by 50%. So if we can get everyone's cigarettes down or to nothing, we could have a reduction in stroke that's substantial and perhaps reduce 10 to 15% of all strokes in the country. So every cigarette counts. Now the other approach is the high risk approach. So one is to lower everyone's risk level in the same way that we all have to wear bicycle helmets to save the few who have a head injury, and we all have to wear seat belts. The other strategy is to target those who are particularly high risk. So how do we find them? Well, this is really the role of general practice, but it's also our own responsibility to go and get a health checkup. And the GP asks us, what are our risk factors? What's our family history? Have we had a stroke or heart attack? What is our pulse? Is it irregular? What is our blood pressure? Is it too high? What is our ECG? And other biomarkers of risk. So the GP will use the nature of your risk factors and the number of them to try and estimate your risk of stroke per year. And the more risk factors, the higher the risk. For example, if you're a 70-year-old man and your blood pressure is 120 millimetres of mercury and you've got no other risk factors, you have about a 5% chance of having a stroke in the next 10 years. But if your blood pressure is 180, it's about 10%. And if you're diabetic, it increases. And if you smoke, it increases. And if you've got atrial fibrillation, it increases. And if your ECG shows you've got a hypertrophied left ventricle due to high blood pressure, it increases. And there's more sophisticated risk prediction tools that you can log into, put in your own data, and work out your own risk. We also ask whether you've had a previous stroke or heart attack, because with increasing risk factors, that cranks up your risk. But there are still some people who have never had a stroke or a heart attack who have a higher risk than some who have had one who have much less risk factors, like a young girl, for example, with a stroke of the eye. But ultimately, the GP is going to try and classify you into low risk or high risk or perhaps medium risk. And the reason is because if your risk is less than 2% per year to have a stroke, you're probably doing quite well, and maybe you just need to continue with modifying your lifestyle. Whereas if your risk is quite high, more than 4% per year, you not just need to modify the lifestyle, but we also need to implement drug therapy to lower your risk with blood pressure and cholesterol, etc. And lifestyle is important because even just taking up regular exercise can reduce your systolic blood pressure by 5 millimetres of mercury. And not adding salt to your food can lower your systolic blood pressure by 5 millimetres. And not drinking so much can lower your blood pressure. Well, you might say only 5 millimetres, or perhaps both of these only 10 millimetres. Well, if you've looked at the data from 45 randomised trials where people have been randomised to a systolic blood pressure that's 10 millimetres systolic lower than not, there's a reduction in the relative risk of stroke by about 41%, somewhere between 13 and 48%. And you don't just have to get 10 millimetres lower. Every millimetre counts. The more you can reduce your systolic blood pressure, the more you can reduce your relative risk of stroke or heart disease. So I'm a 58-year-old man, and if I can lower my blood pressure by 20 millimetres of mercury systolic from 140 to 120, I can reduce my risk of a stroke by 2/3 and my risk of a heart attack by half. Or just a small reduction will have a substantial benefit just with lifestyle modification. And there's good evidence for this now. There's just been another randomised trial where people who are at high risk were randomised to intensive treatment to lower your systolic blood pressure less than 120 compared to standard treatment to accept a blood pressure about 140. And the people who aimed to get their blood pressure lowered had a significant reduction in stroke and major vascular outcome events. So intense treatment is more effective. That's blood pressure. What about cholesterol and saturated fats? Well, same story. Each one of these is a clinical trial where a patient has been randomised to no statin to lower cholesterol or a statin, and for the prevention of a first ever stroke or a second stroke. And when you pool all the data, there is no doubt that taking a statin, if you're at high risk, reduces your risk of a stroke by a relative risk of 0.82, or that's an 18% relative reduction with confidence intervals that don't overlap with a ratio of 1:1. So there's about a 20% reduction with taking a statin if you're at high risk. And that risk reduction is greater the more that you lower your cholesterol. So like blood pressure, every 1 millimetre you reduce your LDL cholesterol, there's a 21% reduction in risk of stroke. So if you get your cholesterol from your bad cholesterol down from like 4 to 2, you'll take your risk down by 42%. And so we need to be more intensive in our high-risk people. And then thirdly, if your GP does find you've got atrial fibrillation, that irregular heartbeat, don't just sit on it. You need your blood thin with an anticoagulant. And these 6 trials of warfarin versus no warfarin in people who haven't had a stroke and in people who have had a stroke show consistently that if you have warfarin, you have a reduced risk by about 2/3 of having a stroke compared to if you don't take warfarin. So that's pretty good, a 2/3 reduction. But not many people like rat's poison. So the pharmaceutical companies and the basic scientists have developed some new anticoagulants that don't need monitoring. And they're dabigatran, rivaroxaban, apixaban and edoxaban that have all been compared with warfarin, which works by 2/3 reduction. And they found these drugs are even more effective than warfarin, overall adding another 20% reduction compared to warfarin, these new agents, and they're just as safe. So there's great hope for people with atrial fibrillation, but it's better to prevent it by getting your blood pressure controlled, etc. So just those 3 examples where there's level 1 evidence to lower blood pressure, lower cholesterol and treat atrial fibrillation could reduce stroke in Australia and the world by half. At least a quarter of all strokes are attributable to high blood pressure, at least 10% to high cholesterol, and nearly 20% to atrial fibrillation and heart disease. So we've got to try and prevent stroke, but as a complementary strategy is treatment of people who have actually had a stroke. Why? To reduce case fatality or death and to reduce disability after you've had a stroke. So there are treatments that we'll talk about, but the first thing is you're flying through space when you've had a stroke. You haven't got much time. Time is brain, and we've got to open up the artery, we've got to prevent another stroke, we've got to anticipate, prevent and treat complications, and we've got to start you getting rehabilitated. So if someone has a blocked artery to the brain, we try and give a treatment called tissue plasminogen activator, which is a recombinant form of what we already make in our body when we have a clot form. But it takes too long to work. It doesn't work for a couple of days. So if we give the drug, it can dissolve blood clots. What's the evidence? Well, there's been 9 randomised trials now where people with an acute stroke due to a blocked artery within 6 hours have been randomised to no TPA or tissue plasminogen activator or TPA or alteplase. And you can see that overall there's an improvement in the odds of a good outcome that you're able to carry out your usual activities after the stroke. The odds are greater if you're treated earlier within 3 hours. Instead of 23% of people making a good recovery, 33% do. So 1 in 10 people will benefit from this treatment if they're treated within 3 hours. But it's not just 3 hours. It's just like blood pressure and cholesterol. Every minute counts. If you're treated within an hour, your odds of a good recovery are much higher than if you're treated at 2 hours, 3 hours, and 4 hours. So time is crucial. Even Jeff Saver, a colleague of mine in the United States, has calculated that for every minute we waste getting to hospital and getting the artery open, you lose 2 million brain cells, 14 billion synapses, and 12 kilometres of myelinated nerve fibres, or you accelerate your ageing by 3 weeks. This is not definite, but this is his estimate. One of the problems with TPA is not just the risk of bleeding, but if there's a long clot, like this is the back of the eye here on the right, and this is the left, and this is the back of the head. But here's the middle cerebral artery, just a plain scan, and you can see thrombus in the middle cerebral artery. And this is very hard for a drug to penetrate and dissolve that, and so consequently you're left with a huge infarct, a huge lot of dead brain, and a major deficit. So when one looks at the data for this, the probability of opening up that artery with a thrombolytic falls off dramatically the longer that hyperdense middle cerebral artery. And if it's longer than 8 millimetres, it's almost all over bar the shouting, and you're on a hiding to nothing. Fortunately, we've had a revolution this year. People who have a clot that breaks off and lodges at the origin of their middle cerebral artery or the terminal carotid here, and you do an angiogram, you see the block here. If our interventional radiologist can put a catheter in the groin here and run it up the aorta and go into this spot and deploy this stent retriever and pull out the clot and open up this artery, there can be a dramatic recovery. This is the sort of result. Here's that blockage there. You see the thrombus sitting in the vessel behind your eye to the brain. Pull out the clot and it opens up and restores flow. Now, there have been 5 randomised trials published this year: ESCAPE, EXTEND, MR CLEAN. These 5 in a total of nearly 1,283 patients who had an acute ischemic stroke within 6 hours, and they were randomly assigned to no endovascular therapy or thrombectomy or to the intervention. And you can see that 170 out of 650 made a good recovery compared to 292 out of 633. So that's 26% without the treatment, 46% with the treatment. So that is an increase in odds of a good recovery by 2.5-fold, but it's a 20% absolute benefit. So you only need to treat 5 people. You treat 100, you have nearly half the people walking out independently compared to only a quarter. So you treat 100, you save 20, or you treat 5, you save 1. And the chances of this being a chance or random error is less than 100,000 to 1. So this treatment is incredibly effective, improving the chances of 1 in 5 people without causing any increase in death and without causing any increase in bleeding in the brain. There are 3 things that have really helped this new intervention. One is improved patient selection by imaging. In the 5 trials, we found that the absolute difference in benefit between the treatment and no treatment was greater when patients were selected using CT perfusion. And what do I mean by that? If someone suddenly loses their speech and their strength on their right side due to an ischemic stroke, no blood, that's due to a blocked middle cerebral artery here on the CT angiogram, the CT perfusion measures blood flow and can distinguish the dead brain from the brain that's alive but struggling to survive but hasn't got much flow. So it's extracting all the oxygen it can from the blood, but it's really struggling in time. It's not going to last much longer than 6 hours. But if our interventionalists see that, go in and pull out the clot, in these sort of people with what's called an ischemic penumbra, they can be left with just the residual core and a good outcome and save this function. The second important thing is we're getting better at treating people earlier. You can see in these trials the people who had their brain reperfused with blood within less than 4 hours had a much higher rate of being independent in their outcome than a more prolonged delay to nearly 6 hours. So time, again, is important. And the third thing is better technology. With these new solitaire stent retrievers, we found that the greater the degree of reperfusion or opening up the artery, the higher the degree of functional recovery. So achieving a good reperfusion within at least 2/3 to 3/4 of people improves the outcome substantially. So it's patient selection, it's time, and it's opening up the artery. The other important thing to do when we've got a blocked artery is not just to open it up, but prevent the volcano going off again in the neck or the heart or the chest. Because as we said, 1 in 10 people will have another stroke within a week if something is not done about the cause. And we found that in this UK study in Oxford, compared to the old days where someone who has a TIA, a minor ischemic stroke, they suddenly go weak and numb for a few days or so, or a few hours, with usual care, waiting to go see the doctor in the clinic and then getting the advice sent back to the GP, there's a delay for starting the cholesterol-lowering drug, a delay to starting the antiplatelet drug, and a delay to starting the blood pressure-lowering drug. Well, whereas instituting an emergency TIA clinic where people are seen immediately and started on their treatment straight away to lower their cholesterol, to thin the blood, to lower the blood pressure, there's a reduction in the risk of recurrent stroke in the next 90 days from 10% to 2%, an 80% relative risk reduction with that more aggressive urgent therapy. The other thing to do other than give drugs is to see, is there a volcanic plaque of atheroma in the neck as a source at the origin of the internal carotid here that could be removed by opening the artery with a carotid endarterectomy, or it could be squashed with a stent like this. And there's good evidence that we have that compared to medical therapy, where the proportion of people with a severe narrowing of the artery in the neck who are alive at 5 years without a stroke is about 68%. But if we clean out that carotid artery, despite an early risk of surgery, there's an improvement to about 83%, so a 15% absolute benefit, or you operate on 100 people and you save 7. And that absolute benefit of 15% is even greater if you operate within the first 2 weeks and get rid of that hot volcano in the neck. 1 in 3 people will benefit from the procedure. So we need to get on with it quickly, and in the world of so-called precision medicine, we've come to realise that we can be more accurate than just the degree of stenosis and the timing. It's also about the nature of the plaque, if it's ulcerated, the age of the patient, the sex of the patient, and whether it's an event of the brain or the eye. And we can stratify people into what is their absolute risk of a stroke with a symptomatic carotid stenosis and what is the benefit of cleaning that out. And then the final thing with prevention is not to forget beyond the first few weeks. Long term, 1 in 2 people who've had a TIA or an ischemic stroke will have another stroke or heart attack in the next 10 years. And this is a patient of mine who had a stroke. This is their carotid artery, and they had a ruptured plaque here, and then they continued to smoke and not have their blood pressure controlled, and then they developed more atheroma and ruptured the plaque again and died. And the importance here is to continue with long-term risk factor control and blood thinning with antiplatelet therapy. In addition to acute treatment and prevention, the other thing is when someone has a stroke is to try and prevent and treat complications and sequelae. If someone has a bleed in the brain, there's good evidence now that getting the blood pressure down acutely can help reduce death and dependency and stop the bleeding to continue to grow in the brain, which we see in about 1 in 5 people. And also, if people are immobile after a stroke, they can form clots in the veins in the legs that can go up to the lungs and be fatal. And intermittent pneumatic compression stockings have been shown to be effective in preventing clots in the veins. But more importantly, perhaps, is to acknowledge the sequelae of stroke. When a stroke is, well, I'm sure there's some of you in the audience who can attest to the effect it may have on your cognition, your communication, your perception and judgment, your intellect, judgment and personality, not just mobility, also feeling and also our mood. And so these sequelae of stroke need to be managed. And it needs to be managed by a multidisciplinary team that are not just doctors, but there's nurses, there's physiotherapists, there's occupational therapists, there's a pharmacist, there's a social worker, and there's a nurse coordinator, and there's a research nurse too. So we need a multidisciplinary team that is holistic, patient-centred, and will attend to the patient as a whole. And we've done randomised trials, as you can see, where people with stroke in each of these trials have been randomised to usual care or care in a dedicated stroke unit with that multidisciplinary team, and there's a significant reduction in death and dependency by about a third with good organised multidisciplinary care. As a complement to that, there are other treatment strategies that are helping to improve our patients. For example, if you do damage the corticospinal tract and you're left weak on one side like the right, one ends up with a tone like this and a pattern of gait that can be quite a problem for patients. They can scuff their shoes, they can get poor hand hygiene, and without good physiotherapy there can be contractures. Botulinum, if we get food poisoning and it's in our whole body, it can paralyse all our muscles and kill us. Whereas it's now been used therapeutically where you can use it to inject just single muscles in a small dose and it can paralyse those muscles. So if you paralyse this muscle that's pulling that foot in, we can allow these muscles to extend the foot and allow a better gait. And similarly, if we paralyse these muscles that are contracting and making the fist closed and there's poor hygiene, that might allow these muscles to then be able to overcome that contraction and open up and at least give some dignity to the patient and comfort. The other thing we're excited about is robotic assistance to help facilitate repetitive practicing of tasks using paralysed muscles, because this promotes nerve fibre sprouting and brain reorganisation. So an example here is a treadmill with a body weight support and a mechanical interface to the patient that can simulate walking and enable them to do repetitive steps that helps their brain reorganise and recover. And the other interesting and novel thing is virtual reality environments that we're now using in rehabilitation to simulate repetitive tasks and allowing people to practice skills safely. So here's a patient pretending to walk on a cobblestone floor, and she's in a safe environment, but she's getting the hang of it. So just to conclude, the last thing I want to talk about was future directions, having tried to contain the burden through prevention and treatment. So as I've said, the challenge is this burden of stroke on the global scale, on the personal scale, and in between. And the main strategies are prevention, treatment, and research. For primary prevention, we've still got a problem in our community. We have emerging risk factors such as obesity and drug and alcohol abuse. And unfortunately, we're seeing a number of strokes due to amphetamine use and still a lot of alcohol abuse. And we need to engage all the disciplines to try and lower the population level of exposure to these risk factors. We also need to embrace new strategies. My young patients don't want to access sort of my information, so with the colleagues in Auckland we've developed a mobile phone technology that's downloadable from the App Store and from Google Play called Stroke Riskometer, where people can download this app, plug in all their factors and get their 5-year risk and 10-year risk of having a stroke. They get their result compared to someone of the same age and sex, and it shows them how they can modify their risk by modifying their risk factors. They can also access information about the symptoms of stroke, the causes of it and risk factors, and they can also participate in research if they'd like to with this reducing international burden of stroke using mobile technology study. For the high-risk approach, we need to continue to engage our patients or the population to get an annual checkup with their GP, and for the GPs and us doctors to try and improve our risk prediction tools. We not just need to look at clinical factors, but the lifestyle and environment. We need to look at imaging, blood, the structure and function and expression of all genes, and the structure and function of proteins, so we can identify who's at high risk and unlikely to make the journey of life without intervention, and who's at low risk and is doing well, and to support their regular activities. And if they are at high risk, we can perhaps target even costly or risky or inconvenient treatments because they have a high benefit to harm ratio. The other thing besides prevention is treatment, and although we have a large body of evidence of effective treatments for stroke and to prevent recurrence, sadly it's not implemented widely in the community. There are lots of barriers to evidence-based practice. Doctors need a workplace culture where it's supported to have the access to evidence and to be able to assess the evidence and have the skills and quality to implement it. And they need to be in an environment where it can be afforded, and it needs to be put in context with what the patient wants. And do they actually want this evidence-based practice and its costs and its risks, but its benefits? So access, quality and affordability are key to try and enable evidence-based medicine. The other thing with treatment is to try and improve and broaden our frontiers. We're moving now, as you've heard with Time is Brain, into the pre-hospital arena, and we not just want to implement neuroprotective therapies, but there's now CT scanners that are coming into ambulances, like here in Germany and one in Melbourne now, where the ambulance goes out when you've got a stroke, does your scan and can distinguish a hemorrhage from an infarct, and you can get TPA, thrombolysis, within the ambulance and before you've even got to hospital. So we also need to utilise or enhance our stroke systems, because it's not just the devices that work, and when ambulance officers are called, we need to know which patients should be sent to those few centres that have the expertise to endovascular therapy, and which patients should be going to a primary care centre. And we also need to be able to service our huge state, because people with a stroke in the Kimberley are not going to get endovascular therapy. There's only a few of them here in Perth who do it. And can we use telemedicine to see the patient, see their imaging, and provide appropriate advice and treatment in a remote way? And finally, beyond the first few minutes, how can we protect the brain and promote plasticity, regeneration and repair? Well, the infusion of bone marrow mononuclear stem cells has shown promise in animal models, but it hasn't proven effective in at least this small randomised trial of stem cell therapy compared to control. But there are other studies going on of different stem cell therapy in the UK and worldwide. And we've also heard from a French study that fluoxetine or Prozac has been associated with improvement in recovery. So there's a UK, Australian and Swedish trial that is assessing whether it works, and by blood and functional MRI biomarker studies, in whom does it work and how does it work. So we have a program from the golden hour in the ambulance through to acute hospital intervention, brain recovery and implementation that I hope will ultimately improve outcomes. But the final challenge is to really improve the efficiency and impact of our research, and not just to complete the research and have it implemented, but it has to translate into improved health outcomes for our individuals and our populations. At the moment, I've told you about the tip of the iceberg, the effective therapies. But underneath, there's a huge iceberg where we've done many trials that have not proven effective. Some have been false positive initially and later proven to be not effective, and some of them might be false negatives. So if we're going to improve the efficiency in our research and not just go round and round in circles, we have to involve patients and clinicians in setting the research agenda. We have to address novel questions by actually reviewing what is known and what isn't. We need valid results internally and build quality into the design and conduct of trials, and don't just rely on monitoring to address subsequent quality concerns. We need to have outcome measures that are important to the patient. We need heterogeneity in the design to increase generalisability. We need to streamline the almost overwhelming ethical review process. And we need our protocols published before the data are collected and analysed. We need to publish our methods in full. And we also need to train the scientific workforce and the journalistic workforce in peer review, interpretation, reporting and dissemination of research. And finally, we need to seek to replicate. We don't just want studies in white rabbits, we want them in black fish. And we want to make sure that, for example, if a study comes out that's positive in Chinese, is it generalisable to other nationalities? So we want to share our data and protocols and collaborate among participants in research, from sponsors through patients to CROs and through investigators and research personnel. And this will require integration among stakeholders across the discovery care continuum. And academic health systems is one measure of integration, or one way which we can integrate by, which includes health systems, medical and allied health schools and research programs that are integrated and for delivering outpatient and inpatient care and integrated with education, research, the community and patients. And we're getting there. You know, we've seen the Fiona Stanley Hospital built with the Perkins alongside. We've got the QE2 Medical Centre at Sir Charles Gardner with the Perkins here, and we've got, for example, the opportunity to implement good electronic health record data for research as well as patient care. And we've got what Peter Thompson is leading, the West Australian Health Translation Network, where Perkins and QE2 and Royal Perth and PMH, Edith Cowan, Curtin, UWA, they're all integrated, and we're getting there with developing an academic health science centre. So I've tried to give you some overview of the challenges for stroke patients and the community. My last three slides, which are really probably the only slides to take note of, are one, if you have not had a stroke, an ounce of prevention is worth a pound of cure. So go and see your GP and get a checkup like you would for your car. And make sure you get a thumbs up for everything. And be rigorous and make sure my blood pressure really is well controlled and my cholesterol really is controlled. If you're going to do it for your car, why not do it for yourself? Secondly, if you are having a stroke, check if it is, or your friend or husband or wife is, have you got a positive face-arm speech time test? Time is brain. Get on with it. Call 000. Otherwise, your brain will be falling away, and get an ambulance and don't go to your GP and just wait. And thirdly, if you've had a stroke and you're 6 weeks out here and you're wondering, how can I get better? Or you're down here and you're plateauing and you're wondering, how can I get better? In addition to physical and pharmacological therapies, take charge. If you're seeing yourself like this, whereas this is me, and this is my stroke that's overwhelming me, and I'm just a weak, mute, tired, lonely, sad, dependent old man, take charge, and this is who you want to become. Where the stroke is just a small part of you, and remember who you are. I'm a mother, I'm a father, I'm a lover, I'm a friend, I'm a joker, I'm generous. So ask yourself, what am I afraid of? What would my best day look like? And what do I want to do with my life? And you'll get there. Thanks for your attention.